Here's Heather Taylor from the Cornwall Primary Care Training Hub to talk to us about the Diabetes Super Clinic that they set up.
Good afternoon, everyone. As she said, I'm Heather Taylor. I'm a practice nurse, and I also work for the local training hub, delivering diabetes recovery work across Cornwall, and I'm also part of the education team. So I've got a mixed hats really, but my passion does lie with diabetes. And I'm just going to tell you a little bit about what we've been doing in Cornwall to look at different ways of delivering care for our diabetic population. So this is the rationale behind the clinics, really. What we wanted to do in Cornwall was to improve the uptake and the delivery of the routine diabetes care across the county, using the 9 care processes, with the ultimate goal of improving our 3 treatment targets post-COVID recovery. And there was a little bit of money available for us to do some extra training sessions with our colleagues across primary care. So we use figures, and we kind of identified practices that have not achieved the sort of predicted post-COVID recovery targets. And the common theme across these practices were they're in areas of high deprivation. So again, thinking about health equalities, which is on everybody's agenda now, these were the clinics that we approached to do some pilot sessions for us. And the reason we did them on a Sunday was purely from a staff point of view. We know that our colleagues in the local labs at the local hospital had a skeleton staff at weekends, especially Sundays, and it would only take 1 or 2 abnormal potassium levels to sort of put a stall on the lab processing, and then that has a knock-on effect with our out-of-hours 111 colleagues that would have to act on something that was deemed as an urgent blood result. So the reason we did them on a Sunday was that we could spin the bloods with the centrifuge, store them overnight, and then they could go into the lab system in the normal working day on the Monday, which wouldn't have a massive impact on the day-to-day workload of colleagues. So that's why we came to do it on a Sunday. And the reason this all happened really was just an accumulation of working with different colleagues around the diabetes arena. I was working with a project manager to do some diabetes recovery across the county, and we used the funding to just do little pockets, some surgeries concentrated on recovering the microbia on foot check, and all personnel in primary care to try and improve the ACR uptake, which we know is a national problem. We also ran some virtual clinics with one of our endocrinologists, where they came out into primary care and we did virtual clinics and picked low-hanging fruit. So we looked at people with a HbA1c of 58 to 75 to see if we could optimise the medication, and that worked really well. And then we started talking about delivering different ways of working and being a little bit more efficient. And we looked at one PCN that even if everybody turned up for the 8 care processes, they could only actually have capacity to see 75% of that population. So even with 100% attendance, they couldn't physically do it in a year. And then we laughed about the D team producing a team together that would helicopter into a surgery, deliver the 9 care processes, and then move on to the next practice. But that hasn't happened as yet. And so then we just wanted to try and navigate this across the PCNs, and we picked a couple of practices that volunteered to do pilot projects with us. And the Clays practice in Roach, again, an area of social deprivation, volunteered, and we're really 100% behind this project. These are just a few figures of what we were dealing with really pre and post pandemic, and you can see here that we were doing really quite well as national numbers, but you can see how it dramatically dropped off post COVID, and this was across most of the practices in Cornwall. So this was one PCN in Cornwall. This is another PCN that have been really supportive in trialling these different ways of working. So this is in more the southwest of the county, and again you can see the recovery figures are really quite alarming compared to national and PCN averages. The surgery at the bottom of this one, VO surgery, is the one that I've spent a lot of time working with the team as well in upskilling the staff, the healthcare support workers, the registered nurses to upskill the diabetes care, training the staff to deliver training sessions for structured education, and enabling the staff to sort of initiate insulin and GLP-1 therapies. So we spent a lot of time with this practice, and they've been really, really supportive and really keen to change and improve the way that they deliver the care for the patients. And then the third team was one towards the northwest of the county, this was a very mixed area, so it reflected about the shortcomings of the nine care processes post-COVID. But again, another PCN that had the only diabetes care facilitator for a PCN across the county, and she's doing great work. So this is what we started with when we decided to pilot the Super Sundays. And this was kind of the web that we created, but bearing in mind the patient is in the centre of this, because they're the person living with diabetes, and they're the person that needs to have the support and the encouragement and the care to improve the diabetes. And involving that patient in the decision-making processes is really important to us, because we know evidentially that if patients have a big part to play in the decision-making process of the care, they're more likely to be successful. And as you can see, how it widens out with the diabetes immediate team, and then we invited our colleagues, yourselves from Diabetes UK. We used Volunteer Cornwall. We used our retinal screening colleagues. We also used our structured education team to try and encourage patients to sign up to do that training, because again, we know that people who attend structured education, the long-term outcomes for the diabetes management are really, really improved, which is a reduction in the mortality as well, and the potential problems of complications associated with diabetes. So this was the team that we kind of built together. And how we sort of put it into practice was just lots of communications, lots of planning, making relationships with all these different people, and just knowing that we all had that common goal to try and improve patient outcomes, which what made it a success. All the people that we worked with really wanted it to work, and we were halfway there then. So we'd meet with the teams in the practice and encourage our other colleagues from the voluntary sector and Diabetes UK to meet up virtually, decided which group of patients we were going to invite, informing the patient what was happening, and that it was a different way of working and what would happen on the day. And that evolved through the 3 practices that we did it, and we kept learning from each clinic that we delivered how to make things better. But the biggest thing that we found was a success was actually reminding that patient on a Friday that they got that appointment on a Sunday, and not to forget that important urine sample. And having a lead for all the communication saved a lot of time, because we weren't wasting time trying to send emails to everybody. One person got the email and then sent it out to the person she thought was appropriate in that team that they had. So then we introduced our retinal screening colleagues to check what their availability was, looking at what the local hospital had capacity, and just making sure that they knew that there was going to be a lot of samples coming to them on the Monday. And that was all set up and we were ready to go. But the most important thing is to get organised once you've delivered that clinic. So making sure that you've got time allocated to process those blood results, and making sure that you've got some clinic time, probably 2 weeks after they've had their appointment, so we can offer these patients that do need follow-up a timely intervention to optimise the treatment pathway. We would tell the patients on the day that they would either have a care plan posted to them, an email, a telephone call, or they may be asked to come in and have another conversation about the diabetes results. And we planned to do that within a 2-week turnaround, so it was timely and the patient wasn't hanging around for too long. We also made sure that our staff that were involved in the clinics and our patients that attended did an evaluation to see what they got out of this way of working. And again, we used that to build on future clinics. And then we made sure that the patients that attended had a review at 3 months if they'd had treatment changed, and 6 months if they hadn't had any treatment changes, which aligns nicely to the NICE guidance. So this is how it was set up, and this is how it was delivered. So when you're looking at the kind of patient you want to invite to these Super Sunday clinics, there's nothing sort of fixed in stone. So the first clinic we delivered in November. So we picked everybody who was due an annual review in the birthday month of November, and the clinic wasn't filled. So then we looked at October to see who'd not attended, and we invited that group of patients. And then we looked at patients who'd not been attending sort of over the last couple of years, so sort of habitual non-attenders. and we managed to fill the clinic with that group of patients. Some surgeries decided they were going to sort of act on the 18 to 39-year-olds, so they could offer that preconceptual care that was relevant. Some groups wanted to tackle the patients that had not been diagnosed very long to see if we could optimize their care, and again with research and guidance, we know that's a good group to tackle into. So one of the surgeries in the first phase of clinics decided they were going to do some extra work in this Sunday clinic and try and find our missing population who had undiagnosed atrial fibrillation. So we just used one of the handheld one devices, and as they booked into the clinic and were waiting to be seen, one of our colleagues would just ask them if they'd hold on to the wand, and if we suspected atrial fibrillation, we offered the patient an ECG at the clinic. That was assessed by a clinician. And then we actually identified quite a few patients with undiagnosed atrial fibrillation, which again was another unexpected outcome for our clinicians that decided to work this way. And again, the patients that were diagnosed were quite alarmed, because mums, which is a bit like what a lot of our patients that we diagnosed with atrial fibrillation say to us. And these are some of the immediate results that we kind of found when we'd done our first wave of super clinics. And you can see every one of the practices in the first three test centres, if you will, all improved dramatically, and a lot better than the rest of our colleagues in Cornwall, especially in the 3 treatment targets. And I think if you're embarking on doing this kind of clinic, because you're seeing more of the population and increasing the footfall of patients and the results, you're going to see a rise in people that may not be in target because you've never done the blood pressure for years, you've not checked the HbA1c or the cholesterol for years. So initially you'll think, oh my word, look at these numbers, they're horrendous. But once you get 3 months down the line and 6 months down the line, and we're optimizing treatment and giving our patients education about the disease, you'll see the 3 treatment target results improving, and it won't take very long. But it's a bit of an eye opener when you look at your results and you think, oh no, this is awful, we're doing worse now, but it gets worse before it gets better. So the unexpected outcomes that we've discovered from delivering this kind of care was that each super clinic got better because we learned from our mistakes, and it was very fluid and it was evolving. The improved patient communication, we did a lot of phone calls. In this day and age, we do a lot of texting, don't we, and AQRX messaging, but the actual word of mouth and that phone call, although time consuming, was really effective to getting patients to engage. We forgot to tell the first group of patients not to drive when they were having retinal screening, for example. And we kept reinforcing bringing in your urine sample, and we sound a little bit urine obsessed in Cornwall, but we're not. But we do have to get our numbers up for our microalbuminuria samples. We had a really reduced DNA rate compared with the Monday to Friday sessions. We had great patient satisfaction on our evaluations of our one-stop shop. The staff enjoyed working because they didn't have any other pressures from anything else in the surgery. They were just purely there delivering the 8 care processes. We do want to emphasise that we did see that the missing part of this delivery of service was the podiatry team that couldn't accommodate us. So if I use an example on the first clinic, we did 18 referrals to podiatry for abnormal foot screening. And when we reviewed those referrals, there was only 2 patients that actually had to have anything actively done with our podiatry colleagues. So on reflection, if we'd got a podiatry colleague on site, we could ask them for a second opinion, and they could have told us then, no, that one doesn't need referring, which would have cut down on the admin for doing the referral, sending it to podiatry, and then for podiatry to act on it. So, but that's still a little bit of our Achilles heel, really, in Cornwall, that we're not lucky enough to have our podiatry colleagues with us. But the biggest thing is how much time we're saving in the weekday clinic. So if we see 80 patients, that's 40 hours of appointments that are free in practice to see other groups of patients. We know diabetes is only a small part of primary care, but we could deliver other kind of clinics that's free because we've got that 40 hours of time free in that clinic, which doesn't sound a lot, but you can pack a lot into 40 hours when you're looking at patients in general practice. So just to bring it up to date, we can see here in the last figures that ended March 2025, The 3 practices that we highlighted at the beginning of this presentation are still functioning really highly in Cornwall, and you can see the percentages there for the care processes are quite fantastic. The average in Cornwall is about 53%, so we can see that by not just delivering the Super Sundays, but the staff's approach to different ways of working and making every contact count is really relevant, and it's so evident with these numbers. Makes me really happy. And the 3 treatment targets, although still got a lot of work to do, we're still pitching really well in Cornwall. And this is again something that we follow up on, and I'm still actively working with these teams to see how we can change different ways of working, again to optimize these 3 treatment targets will, you know, help our patients with the long-term complications that are associated with diabetes. And these are the savings that we've kind of reflected on. Most of our patients only need 1 appointment now, and it's done meaningful and done to a high standard and making it worthwhile for the patient and the member of staff. The DNA rates were really low. When patients didn't turn up on these Super Sundays, we had the capacity to ring them because nothing else was going on in the clinic, and they'd forgotten and they came in the afternoon instead, saving time in the working week. And then when the patients who do need follow-ups, because we've kind of screened out the ones that don't need to come in and have a face-to-face, we can concentrate on our patients with diabetic, more complex needs. And then to make it cost neutral, if we do referrals to our colleagues for smoking cessation or weight management, if we deliver a vaccine, pneumonia, RSV or shingles, we can get a payment attached to that in general practice. And this is all supporting the cost implications of delivering a service on a Sunday, really. And it's not cost neutral, but it does certainly help to the final bill. And these are just a couple of testimonials, really. Chris Reed's our Chief Medical Officer, who's really behind this way of working, which helps. Claire Bolton is the only diabetic specialist lead for a PCN in Cornwall. Claire's done a lot of work with the Super Sundays. They've delivered 4 in her PCN and are adopting this again moving forward. Claire's really, really passionate about diabetes care in Cornwall and has been a great support to the diabetes recovery team. And Rob is a clinical pharmacist, and he's a partner at the first practice, the Clays, and he's really, really pro this way of working, and they're trying to introduce this way of working for other long-term conditions such as cardiovascular disease and respiratory illnesses. So they're really 100% behind this way of working. So as you can see from this slide, we've got Gary and Keith from Diabetes UK, and Tracy's in the yellow t-shirt, she's the project manager. Marcy is from Healthy Cornwall, and Hayley is our diabetes new educator. They painted the nails blue for the day to get in the theme, and these are some comments from the patients that attended that day, that they just thought it was a really good way to have everything done in one. It was easier for them because they didn't drive. One patient said that managing the diabetes wasn't easy, but the advice and support received today was really useful, and then everything in one place made the event really worthwhile. Bloods, ECG and eye test, pick up useful advice. And that's one of the biggest things, because we've got this marketplace approach. While they're waiting to see the clinicians, they're chatting to Healthy Cornwall, they're chatting to Diabetes UK. There might be a social prescriber hanging around to see if there's anything they need. At one event, just as a by the way, we had a patient that had been through everything, spoke to 2 different clinicians, and actually spoke to one of our Diabetes UK colleagues about how depressed she was, and she was actually feeling suicidal. So there was a brief intervention, and that person saw a clinician that day, and hopefully had a really good outcome from that. So what they're not telling clinicians, they might tell somebody who's not in a uniform. So that was a really good win for us on that day. If we'd done nothing else, we saved one person, which was quite nice for us. So our future for Cornwall is to hopefully carry on doing more of the same. We have got some funding to roll it out across the county. We've just recently sent out expressions of interest for surgeries to sort of to adopt this way of working, and we're doing some webinars at the moment, just trying to promote it, to try and get an average in Cornwall from 53% up to 73% by the end of March 2026. So it's going to be another challenge, but a useful challenge to improve our patients' diabetes care. And we're really grateful to Diabetes UK for continuing supporting with us. And what we want to do is try and reduce these complications associated with diabetes by seeing these patients teaching them, encouraging them to be part of the decision-making process of the care, and making patients have a little bit more ownership on the diabetes. And so that's where we're at in 2025 with diabetes in Cornwall, and still working to improve it every day. Thank you.
Thank you very much, Heather. It was great for you to take the time to come and tell you about the super clinic, and it's great to hear how well it's done and how it's going to be rolled out further. So yeah, thank you for taking the time, and I hope that everyone's taken some tips and learnings from hearing what you've achieved. So thank you.